Welcome to the Dental Forecast. Join Dr. Craig Packer, Dr. Joe Field, and their incredible guests as they expand on the Gen 4 commitment to usher in the next generation of dentistry. Stay with us as we delve into cutting-edge techniques and discussions shaping the future of dental care, right here on the Dental Forecast.
Hey everybody, welcome back to the Dental Forecast. We have another really great and compelling and interesting show for today. And it's a hot topic right now with fluoridation. And we've had some interesting things happen in specifically in Utah, but this is something that we could see across the country as time goes on. And yeah, I think as dental healthcare professionals, we need to be not only educated, but be advocating and having these conversations. And so we have an expert with us in this field and hopefully get some information that we can all carry forward in our individual dental societies with our peers and with our policymakers. So without further ado, Dr. Craig Packer, I'll let you introduce our guest for today.
Thank you, Dr. Field. It's good to be with you again. And I am excited to introduce to the podcast today Dr. Boyd Simpkins. Dr. Simpkins is a board-certified professional with the American Academy of Pediatric Dentistry. We all use acronyms, so that's the AAPD, showcasing his depth of expertise in the field. His academic journey includes a bachelor's degree from Brigham Young University. That makes three of us on the call. What a coincidence.
Go Cougars.
Go Cougars. There's not that many around, but we're three of them right here. So graduated from Creighton University, where I also graduated. We just found out, I didn't know Dr. Simpkins then, but I was 2 years ahead of him in the class. And so he graduated in 2002 and I finished in 2000. After leaving Creighton, he went to get his pediatric dentistry. Is it called a residency, Dr. Simpkins? Is that what we call it?
Yeah.
At Children's Hospital of Wisconsin. So welcome, Dr. Simpkins, to the podcast. We're so grateful to have you with us. I thought I would just give you a little bit of time too, to just expound or expand on what, those credentials a little bit and why I found you to have this conversation about fluoridation.
Yeah. So first, thanks for having me on. It's been an interesting month or two as we've kind of gone through a little bit of the stuff here in Utah. Part of what's happened, I guess, to probably bring us together is a year and a half, 2 years ago, kind of getting into the space of working with, I guess, politics is a terrible way to say it, but more organized dentistry. And so wound up being appointed the chapter oral health advocate for the Utah Academy of Pediatrics. And so have been able to work with that organization of the pediatricians in the state, and then was also appointed the public policy advocate for the state for the American Academy of Pediatric Dentistry. And so kind of wound up in this seat. I don't know if it was by accident or if someone pushed me in here. I'm not sure. But what it did do is it kind of gave me some connections. And so I think what happened is when you reached out, the pediatricians got the reach out and they reached out to me to kind of throw me under the bus here so that I got to come on and chat with you guys. So,
well, hopefully it won't feel like a bus went over you when we're done. That'll be good. Well, we're so grateful to have you here to kind of answer some of our questions, explain, because fluoridation, I mean, it's not new, right? That's a controversial topic. I know even when I first got out of dental school, patients would ask about it. Back in those days, we were writing prescriptions for fluoride for our pediatric patients so that they could incorporate that fluoride into their enamel structure and have stronger teeth. Then it got into the water system here, and now it's just kind of weird that Utah, at least from a dental perspective, seems to have kind of taken the step backwards as far as this goes. And I just thought it was interesting, kind of see how it goes, get information out there to other dentists so that they can be more educated on the topic and explain it to their patients. And I guess ultimately the patient or the people, or I feel like in the case of Utah, the legislatures got to decide, what happened here in the state of Utah. So anyway, any thoughts you have, Joe, before we dive into kind of...
Well, yeah, I mean, what would be interesting, because I'll be honest, I think there's newer dentists in our group who maybe don't know. Could you dive in a little bit to the history of like why we were putting fluoride in water and why this even matters?
So it really came about, I guess, in Colorado Springs was where they were having this outbreak of brown mottled teeth. And so it's back in the early 1900s, I mean, way back then. And they found also that these people who had this disease, or I guess they called it, they also had resistant teeth. And so this one particular dentist started looking into why. And it actually wound up with G.V. Black as well, kind of in that same group, who then they found this same phenomena in Idaho. And long story short, over about 30 years, going to different people and chemists, and they finally were able to isolate that it was fluorine in the water that was creating the mottling, but also at the same time was creating the resistance to decay. And so long story short, they went through, they did all the things, and they figured out kind of what was too much, what was ideal, and how did we have aesthetic teeth, but still be able to be decay resistant, right? It just kind of snowballed from there. And, 60 to 70 years of research behind fluoride. And now it's so prevalent that I think for a long time and for us, and we up to, until honestly right now, we still prescribe fluoride in Weber County where we are because it's not fluoridated.
Oh, okay.
Yeah, we have people coming in from different counties around us who do have fluoridation. And so we just have to kind of know, where they're at. But it's been interesting, like looking back on the history as this has all come about, just because it's not something that, I mean, we learn about it in dental school, but do we think about it on a daily basis? No, not really,
Right.
But it's also been interesting too, as we kind of have dove into this whole idea that when we talk about public health, fluoride's like the king. It's one of the greatest public health measures that's been, ever recorded in history. And so to see it go out of Utah was really shocking to, I think, everybody. And so, that's the brief history of kind of where we found it, what happened to it. And then now we're today in 2025 and it's gone in Utah.
Yeah. And isn't that interesting to see that for so many years, it has been, a blessing, right? A help to so many people. And that probably, and we'll talk about it a little bit, maybe as we move on down for, what are some of the reasons why people have turned against fluoride? Maybe that's something we'll kind of get down to in a minute. But it feels like a step backwards to a bunch of dentists, right? When we realize how much it can really help people in the long run and strengthen people's enamel. And I remember back in dental school, I think what they taught us was that the Fl minus, the fluoride molecule, would kick off a hydroxyl OH minus molecule and turn hydroxyapatite into fluorapatite. And that's how much more resistant that tooth would be to, the caries process. So,
man, way to bust out the OChem there.
That's way back in my chemistry
Holy
days.
mackerel. That was impressive. Well, so I did have a question, but wait, so it was interesting. I didn't know this, so in Weber County where you practice, it's not fluoridated, but
I'm in Davis County and we are,
most are, right?
Yeah. Mm-hmm.
So anecdotally, when you have patients from there versus outside, do you notice a difference? I mean, what are you seeing in your practice with that?
It's hard, I mean, on an individual basis, right? We see a ton of kids. I gave a lecture this last July to an organization, and just for fun, I decided, hey, I've been in practice 20 some odd years, and so I'm going to crank out how many restorations I've done, right? Extractions, fillings, crowns, whatever. And last July, it was 86,000. Just myself, which is insane. I really honestly couldn't give you any data on being able to see from one to the next, just because it's going to be the demographic they're going to see in the public health access, right? You're going to be able to see that 25 to 40% reduction overall, which is really where public health runs to. And those of you who are familiar with what's called the Fisher-Owens model of healthcare, it's the probably most accurate model that's set up. And what it is, it gives spheres of influence when you talk about public health measures and prevention, right? And so the tiniest sphere, which all of us who've been through dental school, is that lovely little Venn diagram where, you got the three circles and where they come together, that creates the disease, substrate, bacteria, and what's the last one?
Sugar, carbohydrates,
Yeah, and tooth
food.
structure.
Yeah.
Yeah, I gotta have those three. So,
Hmm.
and what happens is that in this Fisher-Owens model of healthcare, you have the individual, right? And so when looking at it's in an individual basis, public health really is not super effective, right? Or prevention. So then you step out to the next sphere, which is going to be the next community, which would be family. So if we make adjustments inside of family, prevention methods start to kick in more. That's where we start to see some effect inside that. Then move out to community. And then the bigger you get in this sphere of influence inside this Fisher-Owens model of healthcare, the greater the impact it has on the global population, right? Which is where fluoride is at, which is the larger sphere. And so that's where you start to see the effects. Now, if I were to run just like a demographic, it would be hard to also say based on who comes to me, because as a specialist, we get so many referrals for like the worst, right?
Right.
I've done 6,000 general anesthetics in 20 years, just
Hmm.
because of the amount of decay that I see. So hard to say. I wish I had a great answer for you, but statistically, yes. And it's interesting in Utah too. About 62% of water supply was fluoridated up until this decision. And it was Sully County, Davis County, and then there's fluoride in Bray. And so, so like kind of that area. But that's it. But it also hit 62% of the population because of how concentrated that population
Those
was.
counties are, right.
Yeah, absolutely. Yeah. So
Yeah. Interesting.
I think that's really interesting information. And I can remember, I think I was a senior dental student, and we went on a mission trip, right? International mission trip in Nicaragua and Costa Rica. And we went in two different towns, literally adjacent towns and cities. And one, they had very little cavities amongst the kids, right? Next one, completely like blown out mouths with decay, and literally just the adjacent town there. And I was digging in with the mayor and the city officials, and the big difference that I could see is one town had fluoride in their water and the other town did not. And so it made for these kids that big of a difference that we saw it, and it was very noteworthy about the amount of decay and the decay rate in these kids just because of that one thing.
that's awesome.
Yeah,
Very
that's
cool.
interesting. I always, and maybe Boyd, since you were in Omaha also, and when I got to Utah in 2000 and started practicing with my dad here in Farmington, the Davis County water was not fluoridated at that time, but Omaha area was either naturally or fluoridated from the community system. But I can't remember which. But I remember coming back to Utah and thinking I was seeing more decay among the young population that I was working on than I was seeing there in Omaha. And in Omaha, we worked on the more impoverished people that would come and seek care at the dental school. And in Utah, it was just the normal population. And I just remember being surprised at how many people had cavities. Now, I guess Joe's question to me, which maybe he wasn't going to ask, is did that change from 2000 through the fluoride years and then now again too? And I guess that's also hard to say in just a specific practice population. I do feel like maybe it has changed a bit, but it takes years for that fluoride to work into those structures while they're developing and those kids to grow up. And maybe this is about the right time for me to start seeing big changes, and now we're pulling it out again. So
Yeah.
I don't know.
Yeah. As we went on, and the inside joke was always we're looking for prevention by keeping the fluoride in the water, right? We're all going to have busier practices when it's taken out in the next 5 years. I mean, that's essentially what we're going to see, which we're seeing that already in Calgary, right?
Yeah, right. Yeah. And that's one thing I was going to mention is Calgary had it in the water. I just looked this up just before we started. They put it in the water in 1991, took it out in 2011, and then just voted to put it back in again. And it's supposed to start this spring, which is, we're going the exact opposite direction of Calgary.
Yeah.
because they saw what a difference it made in their children in Calgary.
So can you guys, because you guys are on the front lines of it, what's been the conversation there in Utah? Like what got us to this point?
That's a super interesting conversation. So, as chapter oral health advocate, actually, to be honest, I was a little bit behind the eight ball. The Utah Dental Association and the Utah Oral Health Coalition, I mean, they were the ones who saw this right out of the bat. I came in a little bit later, and so kind of rode their coattails, which for me was actually really great to see just because they have so much experience inside these spaces. But essentially what happened was a representative from southern, like Utah County area, which ironically is not fluoridated, put up a bill that removed it, and as a counterpart was putting in some provisions so that essentially the fluoride tablets or the supplements could be purchased at the pharmacy without a prescription. And so that was kind of the cap. And a lot of it, I think, came down to this idea of medication without consent.
Mm-hmm.
And so kind of, my choice, I want to be, I want to know what's in my water. And then, we're going to stopgap it by putting, prescriptions that are available for, the public to come and get. And it kind of snowballed. And it was really interesting in talking with the UDA. They spoke directly with her. And in the beginning, that was it. And then as it snowballed and it caught a lot of momentum, the anti-fluoride groups just came out in droves. I still remember being at the Senate committee hearing and testifying against the bill. And there were 6 of us against the bill and at least 50 plus anti-fluoride, not community medication, that just throngs. I mean, we were just completely overwhelmed. So it was really interesting to see that and to hear a lot of the stories that were coming out of there. A lot of misinformation, of course, right? Based on just the research that we have. But again, how do you counteract that when it's being, said in a public forum?
Right. What do they have? That was one of the things that I think is one of their biggest arguments is that it's mass medication and why are we mass medicating people? But I think about that and I wonder about putting vitamin D in milk or iodine in salt or, different things like that.
Or folic acid in cereals.
Yeah, exactly. It just seems like, where do you stop? And why have they keyed in on fluoride so hard and so intently? What were some of the things they were saying in the legislation that you went to?
So there really wasn't much comment or question from the actual body. And it was really interesting, too, because we assumed that this would go through the Health and Human Services Committee, but they actually ran it through the Agricultural Committee.
Oh.
Yeah, so they didn't even really propose this as a health kind of situation. It was more, they ran towards the ag for, I guess they control the water source. I really don't understand why, but it was really odd. And everybody had commented on that. But, really the big things that everybody was pushing, at least when I was inside these committees, it was replaces calcium in your teeth and bones, which actually is incorrect.
Right.
Had one person talk about how there was a water main break in Sandy and they essentially lost an entire year of their life. They talk about how it contributed to heavy metal deposition. There actually were a lot of people you were talking about earlier, in order to add this to the water, right? It goes in as a really concentrated hydrofluoric acid, right?
Mm-hmm.
And so they talked a lot about how it was dangerous for the people putting it in and they focused on all of these different areas. And inside that entire Senate committee hearing, which I stayed for the whole thing, there was none of the original idea of mass medication or choice at all. It was just complete anti-fluoride because of health. Really strange. And again, when you have people up there giving personal stories, there was no research behind it. It's hard to combat it.
Yeah.
in the 90 seconds that I had to talk.
Yeah.
You know?
How do you fight this emotion with fact, especially
Right.
when the people who are making the decision, they're not the scientists. They haven't looked into the science behind it, and they're being swayed by these non-peer reviewed arguments about what's happening, in these people's lives and things.
Yeah, absolutely. Yeah. Well, from what came down the tubes to me, just staying in this loop, like I said, I wasn't the one at the top of the totem pole. I was just, one of the little soldiers running around. But the impression that I had was that once it reached the stage that it passed both the House and the Senate and then was on the governor's desk for signature, he really didn't have a strong opinion either way. He was just following what the two bodies had done.
Right.
So had an opportunity to veto, and in fact, there were some conversations with some higher ups in different organizations, but apparently, it didn't go down. So
Right.
So what's the big argument against it then? What are they holding to that convinced enough people to do this?
One of the huge things, and this is something that is thrown out there all over, is all of the studies saying that fluoride in water decreases IQ, right? And so I actually did a deep dive in, and there's actually a article in the Journal of the American Medical Association that just came out January of this year, where they do a meta-analysis of all of the studies that have shown that. And so there are studies from New Zealand. China's huge. There are a ton of studies out of China in regards to this. India, everywhere, like outside the US, not all the places, but all the places that do these studies were outside the US. So there's actually never been a study in the US that shows fluoride and decrease in IQ. And so what they did is they did all these analyses, and there was a lot of them with bias. There were some that didn't have bias. But what they took away from all this was that over 4 parts per million, they did see a decrease in IQ. 2 parts per million, still some. But once you hit the 1.5 parts per million threshold, which incidentally is what the World Health Organization recommends be the level of fluoridation, below that 1.5 parts per million threshold, they actually couldn't demonstrate that that was actually a thing. The problem that you see, though, is that then everybody gets into this halo effect, right? Well, if it's in my water, which I'm pretty sure, and you can correct me if I'm wrong, but it's 0.7 parts per million is what Utah was currently fluoridating. And so what everybody was saying, well, if then I have fluoride in my soda, I have fluoride in, bottled water, I've got fluoride in groceries, then all of this is accumulating. And so the idea is that they're afraid, and I would hear this all the time, that we're causing brain damage for children. Which anytime that you have anything like that that's jumping out there, oh yeah, I mean that's a real concern, and so people are going to jump on that bandwagon, even if there is no evidence showing at the levels we're doing that, we're seeing those effects. Now, again, we go back, and this was iterated inside this article, and there's another article that talks about it as well inside the National Institutes of Health website, but when we look at that Fisher-Owen model, on the individual basis, that really isn't anything. It was like a 1 to 2 point drop in IQ, which honestly, standard deviation, it's really hard to say how that affects things. But looking at the population level, sure, that could be a detrimental thing if we see IQ drops on, a global level. So there we go. And that's usually the biggest thing. And there's always the idea that, well, it's a poison and all these things. It's interesting, though, where it sits on the periodic table, like it does straddle between arsenic and like chlorine and different things like that, right? And, we add chlorine to water.
Yeah, I was going to say,
well.
Chlorine saves lives, right? It keeps our waters clean and pure.
Yeah, so, it's just, it was 1 electron off or something. So anyway, so it's always an interesting conversation. And I have lots of these conversations in my practice. And to be honest, it's really ramped up. And so we are constantly having this conversation with parents. And most of the time, what we do is we're in the office and, they're like, we ask everybody, would you be okay if we put fluoride on? And we're getting a lot of no's now. And so now we're having to dig in, is it because of your concern for the health effects of fluoride, or is it because insurance doesn't pay for it? So we're having to dig into that. And then I'm having constant conversations with parents about that and then alternatives, right? Because as we bring these kids in and we're doing these prophies and all that, we're removing a portion of that fluoride rich layer on the outside of that enamel. And so we want to do something to try to get that back. And so with as much as we talk to parents, you said this before as well, the autonomy is not with us, which again, you could take that back to the mass medication. So we're trying to find other avenues to try to remineralize once we've done these prophylaxis, because we got to get the stuff off, right?
Mm-hmm.
But at the same time, we want to try and remineralize so that we aren't putting these kids at risk by having them come in and then, just the global, carries. I kind of got on a tangent there.
No, that's okay.
Anyway, yeah.
I mean, I'm kind of curious about, before we get off that tangent, so what are you trying to use hydroxyapatite type pastes and things as an alternative if they won't accept fluoride?
Yeah, and we've done the nano hydroxyapatite for quite a few years actually inside the programs we do, but it's also mixed with fluoride, right?
Oh yeah.
We do. We also offer MI paste, which is the casein phosphoprotein, which is that milk protein that pushes the calcium into the matrix. And the thing that's really hard about all this is that they are showing similar effects from the nanohydroxyapatite as far as remineralization, right? It's these tiny little molecules that just pack into all these little missing spaces inside the tooth. And so they are finding effect there. The thing that we have to remember, though, is that when we pack that nanohydroxyapatite back in there, it's calcium hydroxyapatite, right? It's not the calcium fluoroapatite. And so the problem we're running into, though, is even though we're remineralizing, when we look at the pH that it requires to create demineralization inside of a tooth, 5.5 is the norm, right? So once that acid level hits 5.5, demineralization recurs. 20 minutes later, the pH starts to come up, and then it's another 40 to 45 minutes to remineralize again based on the saliva and all the buffering capacity and remineralization that's inside there. When it's fluoroapatite, it's actually 4.5 before you start to see demin. And so when you look on that on a logarithmic scale, that's a 10,000-fold increase in resistance to acid.
The acid, yeah.
Right. And, so those are the limitations that we're running into now. And I'm getting on whatever I can. We've moved into probiotics and all that kind of stuff as well, but we're really missing that logarithmic increase in resistance.
And even those things are amazing, but it's just topical. It's just that last surface layer, whereas the things that we're pulling away are going to prevent that fluoroapatite from being all the way through the enamel matrix, right? All the way through, all the way into the dentin layer. And I don't even know about the dentin layer. I'd have to study that. But yeah, so obviously topical stuff is great, but if it's integrated in during formation, that's way better than that. I didn't look this up, and maybe you don't know the answer. I don't want to put you on the spot, but what level do we start seeing fluorosis? You were talking about putting it in at 0.7. It seems to not cause any sort of cognitive issues, if it's below 1.5 or something like that. But these towns that first figured out that these mottled teeth were also decay resistant, do we have any idea what level their waters were at that point?
No, I have no clue whatsoever. Yeah. I'm assuming just based on all of the recommendations and then just reading through that history, finding that 1.5 being that threshold. I think at 1.5, I would assume that once you get past that, then you start getting the risk. And of course, you're going to have gradations, right? You're going to have the small modeling. You're going to have, and as you get higher and higher, I still remember actually in Omaha when we were in dental school, having someone coming in from a foreign country that was on well water that was crazy high fluoride, and his teeth were literally black and just flaking off, So Yeah, that's the far extreme. So
Yeah. I just Googled it after asking you that question, so I should have done this before.
oh, you're good.
It says the EPA sets a safety standard of 2 milligrams per liter to
Okay.
prevent mild to moderate fluorosis.
Okay.
So if it's under 2, apparently it's pretty safe from fluorosis, but still has
Yeah.
the efficacy we're looking for to strengthen the
Right.
enamel. Yeah.
Right. Yeah.
So, what other things are you recommending for, let's say, practitioners now in Utah to do that see a lot of kids to help offset the lack of fluoridation in the water now?
Yeah, you mentioned some of the nanohydroxyapatite, and you kind of mentioned probiotics. I'm not sure what. Maybe you could explain that a little bit more.
Yeah. So the big idea, and one of the biggest pushes that we've done in my office, and we're seeing it, I think, starting to catch on, is that modulation of the microbiome of the oral cavity really is where we need to push, right? Because if we've got a high residence of acid-producing bacteria, it's going to be a constantly acidic environment. And so we lose the buffer capacity inside of saliva. It's a finite thing, right? You're going to run out. And so if you've got a shift in the microbiome to, more acid producers versus the commensal bacteria, then what we're trying to do is we're trying to balance that out, right? And so the probiotic, it's a chewable, you chew it up, swallow it, totally fine. But it's all like the strep sanguis, strep salivarius, all those commensal organisms that are going to be secreting the ammonia, the hydrogen peroxide. And so what we're trying to do is we're trying to rebalance the biome. Now, the problem with the probiotics that we're running into is that they do. I mean, like we'll see, we'll do some testing inside the office where we can watch the levels of the ammonia and the acidity and the buffer capacity just to kind of, track over time. Just like anything, most information is better when we have multiple points on a data sheet. But it's the diet that supports the bacteria, right?
Mm-hmm.
And so that's where we're using probiotics, is that we're trying to change the environment versus trying to just change the teeth.
Strengthen the tooth. Yeah.
Yeah, because you can do both. But we all know that if you're going to sip and snack all day long, it doesn't matter if you bathe in fluoride, you're eventually going to break down,
Mm-hmm.
So, yeah. So that's where we've moved. And I mean, you could even go further. Fluoride's really effective. Fluoride's great. It's got a proven track record. Just like anything, poison is dose dependent. Right. And so keeping it at proper levels, you're going to avoid the issues. When we look at this nuts and bolts, and you can go way back to like Weston Price, like if you really love that kind of stuff to kind of dive into, which nerdy enough, and my wife, she really loves it when I talk about this with her. So it goes back a little bit to what Joe was talking about, where, Weston Price went into these, I guess, quote unquote, untouched civilizations where they were on their primitive diets. They hadn't seen the Industrial Revolution. We weren't seeing processed foods. And so we're seeing him moving into these areas where not only is there no dental disease, there's also better facial development and also better overall health. We're not seeing the chronic diseases. And there are other myriad of books that you can read that kind of chronicle all of this. And so really, fluoride is only around because of how crazy and terrible our diets are, honestly.
Mm-hmm.
If we look at this as a global health initiative, the only reason that we're even talking about fluoride and we're reducing cavities is because of big sugar, because of processed foods, because of lack of nutrition inside of our diet. So we can then go back to the whole idea that the population that's going to be affected by this the most is going to be those that are children, A, but then B, those who don't have access. So those who are more in the low socioeconomic or impoverished status.
Higher risk patients.
Exactly. Yeah. And that's where caries risk assessment comes in for us as pediatric dentists. I got a high risk kid, a lot of those things all hold true. And so not only do we have these kids who are at high risk because of low oral health literacy, but then you're also in the food deserts, you have less availability of fresh fruits and vegetables, you have more processed food that's being consumed. and all of the metabolic issues that go along with that, that not only tooth-wise, but then we're seeing the rise in obesity, we're seeing the type 2 diabetes showing up, we're seeing all of these long-term chronic situations that honestly, as we watch, and I've seen the models where we see Medicare and Medicaid spending is supposed to be flat. And it stays flat on the projections. It's Medicare that goes off the charts because we're not addressing the nutritional needs of our nation. So really, fluoride's a stopgap. We're just trying to do the best we can because everybody else is making a ton of money by putting a whole bunch of crap on our shelves in the store that we buy because it's cheaper.
Well, and I say this with a ton of sarcasm, but the irony of Utah being the first state to do this is another phenomenon in Utah are the soda shops. I mean, you guys got the Swig and, the Sodalicious and Fizz. And like, I go there and my teeth hurt just being in Utah because of all these places. And now, we're taking the fluoride out of the water. It's going to be rough.
It's okay, Joe, because they also sell sugar cookies, right?
Oh, good. Okay.
Yeah. So
you got to wash the sugar cookies down. Totally makes sense.
Yeah. The best is when they sue each other over the sugar cookies. Those are that's my favorite. Yeah.
Well, so if you demineralize the teeth and then instantly put sugar in there, it's a win for dentistry, I guess.
Yeah.
The problem is, and when you were talking about that, Boyd, is that some of those same people who are struggling with this impoverished cycle are also, and having this higher decay rate, are the same ones that come into your office and they can't afford the dentistry that they now need, right? And so I wonder what's going to happen. And this is a whole other conversation. We don't have time to get into it. But I think that in Utah, there's going to be a big need for some public health dentistry. There's going to have to be a place for these children to go outside of just standard everyday private practice.
Yeah. I mean, I'm an attending at Primary Children's. I've been there since 2013, so it's been over a decade. And I think OR right now, we're up to 4 residents, pretty much run an OR daily. And I mean, you're 6 to 8 months to get in.
Wow.
Yeah, I mean, access to care is really tough, and it's really hard to, especially right now. I mean, with the impending Medicaid cuts, I mean, and thank goodness that we have some things in check that we're hopefully kind of relying on, and the University of Utah has been very big with that. But the issue we're going to run into is that as we've moved into Medicaid expansion, right? And this is where we're talking about most of these kids who are going to have the most dramatic effect from the fluoride. When we had this Medicaid expansion which our legislature took on very begrudgingly. So on average, what happens is that to be eligible for Medicaid, you're at 139% of the federal poverty level. And so when they took on the Medicaid expansion, they decided actually to take that cap down from 139 to 100% of the federal poverty level. So we had this huge gap of kids in between there that don't have access. So now, not only did we reduce that, we now take away one of the big public health measures that has been battling that as well.
Right.
So it's like gas on a fire, essentially.
Yeah. It's going to be a crisis. Calgary decided 20 years later to put it back in. So we'll see what happens in 2045, I guess.
Yeah. Well, here's the kicker behind the Calgary as well, is that in order to put it back in, and I don't know the exact number, but it's either 20 or $40 million to have it set back up to put it back in. So they took it out, found it was a bad idea, and then they're going to have to pay the price tag to get everything up and running again. And so there you go.
Well,
we're coming up on time. I'm curious to hear from you, and Craig, you could comment on this as well. So what, as practitioners in other states, what can and should we be doing to keep this from happening in our state?
So if you, did you guys get the ADA newsletters? Did you guys listen?
Yep.
Yeah. If you look on there, you'll actually see the headline. And I haven't had a chance to read through it yet, but it actually has states who have already put in referendums to try to protect that through bills. And so, unfortunately, at this point, it really needs to be at that legislative level where you're going to have to go after that, because where we're looking at how Health and Human Services is being run at this point, Utah's just like the starting point. And that was the big thing. We even, we got letters from the up and ups at AMPD to, take them into the senators, and, none of that hit, but the precedent has been set. And so organizations, really, I think we need to be into the policymakers, and we need to be really just protecting that as much as we can. So, and the other thing that was really hard for me during this whole thing was, even though we're talking about mass medication, right? The municipalities were the ones who voted to put the fluoride in. And I was in Davis County when the referendums went up to fluoridate in Davis County, and it was a vote, and the people decided by a majority to be able to put it in. And so this doesn't also mean that you have to have the medication inside your water, because you put in a reverse osmosis system, you're taking the fluoride out.
Oh, yeah.
Right. So it's not like the choice has been taken away from you. So it was really interesting for me to watch that whole thing play out, because there were a lot of things that didn't make sense to me. And, obviously I'm new to this space, so I guess I don't know it all as far as the politics and the legislation. But at the same time, it was hard to wrap my head around some of the things that just didn't add up.
Yeah. Yeah. It's amazing to me. If we took the chlorine out of the water, we would just have a lot of people with dysentery and typhoid fever and everything else. And yet no one's pushing to do that. So I guess don't quite understand why we went this way, but we're super grateful for your time. And I guess what that is, to answer your question, Joe, a little bit, is maybe we just need to be more involved at an earlier stage. It was almost too late when I heard about it. How do you rally the right people around in the right amount of force at that time to really make a difference? And so start early, I guess, and have a voice.
Yeah. It's pretty sad. And I'm going to throw me and all the other pediatric dentists under the bus right now, but we have no real organization. We've always just been reactive, right? There's nothing that's been proactive inside of our organization. And so we're really trying to change that now. And, unfortunately, people are going to get hurt by this right now, by us, not being able to get our ducks in a row quick enough, is the kids. That kind of sucks.
Yeah. Well, thank you so much for your time. Amazing. Before we pushed record, you said this was your first podcast, but man, you killed it. You did awesome.
Well, thank you. Yeah, I pretty much just do what I do every day. I just talk about all of it. So I just talk about it. So
we really appreciate your time. This is going to be great for our doctors all across. We're in 16 states right now, and we'll get listeners that are outside of the Gen 4 community also. And I think this really could be a helpful thing. Hopefully make a difference in other places in the country, and ultimately benefit the kids and the patients. So thank you again.
Yeah. Thanks, Dr. Simpkins.
No, thanks, guys. I appreciate it. This is actually pretty fun. I was coming in as thinking,
when it's done, we'll send you the link and you can listen to it. Yeah.
Well, that sounds awesome. Yeah. Okay. Thanks, man.
Well, thanks everybody for listening to the Dental Forecast, another great episode. And we'll hope to have more good information for you in the future. Thank you.
Bye, everybody.
Bye, everybody.